The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Welcome to the next episode of TMD Demystified. I am Tony Urbanek. Today, we're going to be talking about how common TMD actually is in our environment. What is the prevalence for this problem? I have a lot to say about that and why. Obviously, it is prevalent to some degree, for sure. Everyone agrees on that. Every dentist has to deal with it one way or another. Most of them don't want anything to do with it. That's a fact. In fact, almost all of them don't want anything to do with it because they think it's a big black deep hole and it is just a problem for their practice, which is not true. I've discussed many times why that is not true, because the average dentist is taught that this is a complicated problem, which it is not. When you understand what the pathophysiology is, the real pathophysiology, not the made-up pathophysiology that is taught in dental schools and elsewhere. It's not a big complicated problem. You just have to understand a little bit of cell biology and a little bit of neuroanatomy and a little bit of gross anatomy. Anyway, the title of this episode is TMD is a much bigger problem than thought previously. TMD is a much bigger problem than thought previously. So let's start here. How big a problem is this generally considered? Well, if you read the studies, lots of them, there's lots of studies about TMD as it works out. The studies come from different countries, different populations, different times. They've gone on for at least 40 or 50 years studying the prevalence of TMD. The first scientific article about TMD was published by Dr. Robert Costin in 1934. He was an ENT surgeon. I mentioned his seminal article, which described some of the symptoms and brought it to the attention of the readers that the cause was lack of dental support. In other words, missing posterior teeth. That was his theory at that time, 1934. And that's where all this started. And that's why for 2 decades it was called Costin syndrome. Through the 30s and the 40s and into the 50s, it was better known as Costin syndrome. The prevalence became much more common because the symptoms became more recognized. It became into view of the professions, both medical and dental profession. Primarily the dental profession started taking a look at it. In any case, the prevalence, depending on what studies you read, fall between 15 and 30% of the population. It is well known, well accepted, and again, the studies vary between what percentage is prevalent in females versus males, but generally speaking, if you talk to the average doctor who tries intuitively to treat TMD, he will say it's roughly 90% females and 10% males. And that has been my experience, personal experience after treating TMD patients, both surgically for 36 years and non-surgically for 15 years, non-surgically exclusively for 15 years, which adds up to well over 10,000 people that I've done consultations with, well over 10,000 consultations, and probably more like 5 plus 2, 7,000 actually treated patients with this problem. 2,000 surgically and over 5,000 non-surgically in the past 14, 15 years. My experience is that it's 90% females, 10% males. Let me just drop the fact on you that's in the literature for 70 years, which explains why it's a female problem. No one reads the scientific literature, but it's in there clearly in many different types of articles addressing chronic inflammation. Chronic inflammation is exacerbated by estrogen. That is why TMD is primarily a female problem and fibromyalgia is a female problem. Because of this one fact, estrogen exacerbates inflammation. And all the symptoms are driven by chronic inflammation within the temporomandibular joint, so it stands to reason it would be expected to be a female problem if estrogen exacerbates inflammation. This is not rocket science, ladies and gentlemen. It's not rocket science. It's just a little bit of reading within the science that is already there, which is actually what I did. I read various articles about inflammation, chronic inflammation. I knew a lot about temporomandibular joint, treating it 36 years surgically, well over 2,000 surgical procedures, and then 14 years ago decided the surgical route is not the best, could not be the best route to treat this problem, because a third of the patients would be back within a year or two with the same symptoms, which led to my independent research, which I've talked about extensively, and findings. So back to the topic, what is the prevalence? What is the real prevalence of TMD? Well, we start out in the quote articles between 15 and 30%, depends on the country, depends on the culture, etc. But actually, it's much higher. I quote, and I'll tell you why I quote this. I'll explain it thoroughly. I quote that at least 45% of the female population in the United States of America have and exhibit and suffer from TMD symptoms. Let me run through it again, what the symptoms are. And there is no dispute. Of course, this is all a loaded question. TMD is probably, if not the highest, probably one of the most frequently argued topics within dentistry. And it shouldn't be, but it is, because most of the people who try to treat this treat it from the wrong point of view. They treat it from the point of view that this joint is different. My first discovery was this joint is no different than any other joint in the body. That is a fact. This joint operates like no other. It operates like any other joint in the body. It is not different, as which every dental school teaches, that this joint is different, unique, complicated, because it has a complicated name. Gangliomo-arthrodial joint. Oh my God, that's a complicated name. It must be a complicated joint. It's a joke. This is just simple science. So what are the symptoms of TMD? The symptoms of TMD, undisputed, are frequent and or recurring. And keep this in mind as we proceed as to why the prevalence is actually much higher. The actual symptoms are frequent and or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, a feeling of fullness in the ears, dizziness/vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. These are the undisputed symptoms of TMD. There are a few symptoms I will not mention right now that I have run into. I'm still working out the volume of patients with these symptoms, but I firmly believe that there's a few additional symptoms that are confused frequently with other medical diagnoses. The problem is all these disparate symptoms, and certainly no one argues that these symptoms are disparate, spread out and make no sense as a common cause. They're disparate symptoms, and that's what started the confusion. No one could figure out how you could get all of these disparate symptoms from one particular cause, which is at the point something to do with the TMJ, temporomandibular joint. Well, as it works out, the common denominator is chronic inflammation rather than symptoms being originated in the muscles. They don't originate in the muscles. They originate with chronic inflammation, and chronic inflammation originates within the joint because of three circumstances. I call them circumstances. Circumstances would be bruxism, too much clenching and grinding, acute trauma of various kinds, motor vehicle accidents, whiplash injuries, 4x4s off the back of a pickup truck, bar fights, athletic accidents. Here in Tennessee, a lot of horse accidents, and functional malocclusions of different varieties, functional malocclusions, where your teeth fit so poorly together, or your jaws fit so poorly together, not just teeth, the entire jaws don't match to the point that it overloads the joint, causes damage, creates chronic inflammation. All three of those circumstances do nothing more, nothing less than damage a joint, overload a joint, damage a joint. Just like you can damage a knee or a hip or an elbow because of too much use, too much force. That's where the damage comes from, ending up with chronic inflammation. Getting back to the prevalence. Well, here's the problem. Having those disparate symptoms that appear to be having nothing to do, originating from this little joint in front of the ear, the other professions think that it's something else. They frequently misdiagnose TMD. That's the issue. That is the issue. That is the issue of why the prevalence for TMD is actually much, much higher than the articles in the past journals for the past 40 or 50 years have been insufficient, because they have not included the myriad number of misdiagnoses by the other healing arts, especially the medical doctors. And because I am also a medical doctor and I have the union card to be a medical doctor, I can't be smoothed by the medical profession, because I've studied that, especially in detail, regarding these symptoms, especially these symptoms that are associated with TMD. What symptoms? Frequent or recurring headache, earache, neck pain, upper back and shoulder pain, tinnitus, subjective hearing loss, and vertigo. Those symptoms, if you have one or more of those symptoms and present within the general medical establishment, the last thing, if ever, that the medical doctor, nurse practitioner, physician's assistant will think of, chiropractor, will think of, is TMD. If you present with chronic headaches, bad headaches for sure. Patients complain bitterly of temporomandibular joint headaches, very bitterly. And temporomandibular joint headaches can be extremely, extremely painful and cyclical. They come and go. They are diagnosed by the medical profession as migraine headaches, or at best tension headaches. And the patient is delivered a series of drugs, which don't help chronic inflammation within the temporomandibular joint. They have the wrong diagnosis. That is huge. That one diagnosis, misdiagnosis alone in the United States is done to millions of primarily females, 10% males, 90% females. That misdiagnosis I have observed over thousands of times out of those 5,000 treated cases and over 7,000 or 8,000 consultations, seen it constantly. I mean, at least 50% of the patients that I see with TMD headaches, and I've explained exactly how chronic inflammation creates headaches and various facial pains consistently. But when they present to their physician, they're diagnosed with migraine headaches or tension headaches, given drugs, when actually all that you need to do is decrease the inflammation within the joint by resting the joint using a very simple device that unloads the joint. That's all you do with this thing. You unload the temporomandibular joint according to a protocol. You just don't unload it for 10 minutes. You have to use a proper protocol and decrease the inflammation. So the prevalence with just the misdiagnosis, misdirection of the physicians diagnosing migraine headaches and adds at least 10% of the prevalence to this problem. And then when you include earaches, which is another extremely common symptom that patients present to their PCP, and if the PCP doesn't handle it or want to handle it, he will send it to the ENT, ear, nose, and throat, otolaryngologist, of which somebody's going to look in the ear with an otoscope, a speculum and little light otoscope, and see if they can find inflammation or infection within the ear. Almost exclusively, if you go to a convenient care clinic or walk-in clinic, the nurse practitioner, physician's assistant will, whether she can see or he can see infection, they're not really good at looking through that otoscope, I can promise you that. 100% of the time, if you walk into a convenient care clinic with the symptom of earache, you will walk out with a prescription for antibiotics, 100% of the time. Their thought process is well outside thinking about TMD is causing what feels to the patient like an earache, and it does. And I've explained how that anatomically can occur, how chronic inflammation within the temporomandibular joint can actually penetrate into the surfaces of the external auditory canal and feel like an earache. But it's not an infection. It's not an infection. Antibiotics will handle infections. They don't handle chronic inflammation. Antibiotics don't treat inflammation. But patients walk out with thousands, actually millions of prescriptions for antibiotics when the actual pain is coming from inflammation within the temporomandibular joint. And that misdiagnosis can add on several more percentage points to the prevalence of TMD. Once you get past then the earaches, then you get into the other three non-painful symptoms that are well known, well established with temporomandibular joint patients, which are tinnitus, ringing in the ears, subjective hearing loss, a feeling of fullness in the ears, and vertigo, dizziness. Those three symptoms have the diagnostic name of Meniere's disease. If you walk into a ENT practice with one or more of those symptoms, you will get a very extensive and very expensive workup, probably including an MRI, and you will be told that you have Meniere's disease, of which the ENT surgeons have no solution. The patient will say, well, that's great. Now we know what it is. Why do you treat it? And the ENT doctor says, we do not understand Meniere's disease. We have no solution for Meniere's disease. There are a few doctors who throw things at the wall to see whether they stick, but the average ENT doctor will admit they have no solution for Meniere's disease. On the other hand, it is anatomically shown and proven that chronic inflammation within the temporomandibular joint has access to the middle ear, allowing chronic inflammatory fluids to get into the middle ear, where your hearing mechanism and vestibular mechanism is, causing, when those tissues, when those areas within the middle ear get exposed to fluids of chronic inflammation, they will respond by creating the symptoms of tinnitus, ringing in the ears, subjective hearing loss, a feeling of fullness in the ears, and dizziness, vertigo. So the ENT doctors have no solution for Meniere's disease, but the independent symptoms of independent symptoms of ringing, fullness, dizziness are well-known symptoms associated with TMD. And when you make the inflammation within the temporomandibular joint go away, those non-painful symptoms diminish and go away also over time. It takes a little more time to allow the inflammatory fluids and influence of those inflammatory fluids to dissipate within the closed space of the middle ear. But they eventually dissipate and go down, has been shown, has been proven. And when that happens, it's obvious that the original diagnosis of Meniere's disease has been a mistake, misdiagnosis. And when you add that percentage to the overall percentage of prevalence, now you're into the 40% or more of population. And then you get into the neck problems and upper back and shoulder pain, which has been anatomically shown how that occurs and created by chronic inflammation within the temporomandibular joint. Simply stated, because temporomandibular joint disorder, singular, it's a disorder, one disorder, chronic inflammation, is the identical problem anatomically, physiologically with tennis elbow. Tennis elbow and TMD are the same disease. And when this joint becomes inflamed, it sends signals to the brain stem. It says, I'm inflamed, announces it's inflamed, it's damaged, chronic inflammation. The brain stem says, I'm going to help you out, don't move the jaw. And when that isn't the solution, then it says, hold the whole head tight, and the neck muscles get tight and cause neck pain. And when it continues beyond that, then the signal comes down through the autonomic nervous system. I told you, hold the whole jaw tight, then hold the whole head tight, neck muscles, and then it's hold the whole upper body area tight, the upper shoulder girdle, as we call it, tight. And patients complain of upper back and neck and shoulder pain and tightness, and even arm, hand, finger tingling and numbness when the strap muscles on the side of the neck squeeze the brachial plexus. That confusion will add a few more points when it's confused with cervical spine problems. I mean, I have seen several patients who have actually had neck surgery when the actual problem was TMD. So when you include the misdiagnosis, mistreatment, misdirection from the medical establishment, calling it Meniere's disease or calling it migraine headaches or tension headaches, or misdiagnosing it as cervical spine problems, you add several percentage points to those original papers that show 15 to 30%, and we're up to 45%. Now, the reason I quote 45% is very simple. There was a time, early time, after my discovery of the actual cause, the common denominator of TMD, where I did independent lectures in dental offices. And over a period of 9 months, I did, by count, 41 independent lectures in dental offices of various sizes, in that 9-month period. When I did those lectures, I was in front of anywhere between 5 and 20 females in that independent practice. These weren't large lectures, they were just independent lectures within practices, but I had the opportunity to lecture to the dentists and their staff, and usually staff numbered anywhere between 5 and 20. I always took the opportunity to ask the female staff to tell me, after I enumerated what the symptoms are, how many of you ladies have one or more currently suffer from one or more of these symptoms: headache, earache, jaw pain, neck pain, ringing, fullness, dizziness, upper back and shoulder pain, arm, hand, finger tingling, and numbness, and various kinds of jaw locking, which are also one of the symptoms. Invariably, at least half of the hands went up, at least half of the hands. So on a conservative basis, having a hand showing of over 50%, I just decreased it to 45%. Now, admittedly, that system is not scientific. I don't claim that is a statistical study, but it is a study. It is a study, and it qualifies to be a study, which shows the prevalence actually is something equal to or more than 45% of the females. Now, I've also had the opportunity over the years treating patients and doing lectures and going to scientific events to actually ask a group of females as I spoke the same question. And invariably, whether I'm speaking to 2 or 3 females or whether I'm in front of 10 females, and I say, what percentage of you, how many of you have one or more of these symptoms? And invariably, at least half the hands go up. Yeah, I have that. You have migraine headaches? Yeah, I've been treated for migraine headaches for 20 years. Are you on migraine medicine? Yes, yes. How are your migraines? Well, they come and go. They come and go. Not scientific. Don't claim it to be scientific, but this has been my experience. And for those patients who listen to these podcasts and these episodes, I know, because I've been told by so many, that this is real to you. It's real to the patients. It is not so real to the doctors. It is not real to the physicians. It is not real to the dentist, how prevalent this is. It is not real to the dentist and the physicians, how disparate the symptoms are. They still generally speak of TMD as being localized to the jaw area. They know it's related to ear pain. They know it's related to jaw pain. If the patient can't get to the point where the worst of the worst is, when the jaw won't even open all the way, then someone says, well, it must be your jaw joint. Yeah, it sure is. After 20 years of headache, earache, jaw pain, and neck pain, and then finally it gets so bad that the disc gets in the way, the meniscus actually gets dislocated, and then you can't open all the way. You get to the very worst kind of case of TMD, and finally somebody says, oh, this must be your jaw, rather than migraine headaches, rather than Meniere's disease, rather than ear infections. The prevalence of this problem is extremely common. 45% of females have temporomandibular joint symptoms, and in relatively equal amount, 9 to 1 of males. That is the message for today. I hope I've gotten my point across. And for those patients who are listening, I want to validate your experience. I know what your experience is because I have listened to well over 5,000 cases. I've literally treated over 5,000 cases in the past 14 years successfully. And I validate your concerns and your frustrations. And for the dentist listening, I encourage you to think about this as it applies. If you don't want to apply it outside of your practice, at least apply this information within your practice to the hundreds. If you have an average dental practice, you have 1,000 patients, half of those are females, and half of those, or so, 45% of those of your female patients have TMD symptoms and currently suffering from TMD symptoms. Let me repeat that, doctor. If you have the average dental practice of 1,000 patients, current patients. Half of them are female, roughly. And half of those, 45% of those, currently suffer from TMD symptoms, of which you need to bring it to their attention and correct the misdiagnosis that has been given to them, or maybe no diagnosis. No diagnosis. And that comes across from my medical colleagues who have no hesitation listening to these disparate symptoms and looking at the patient and says, this makes no sense to me. You're crazy. Literally, I have heard that from multiple patients saying, my medical doctor says I'm crazy. This can't be a singular problem. Well, it is. All of those symptoms come from chronic inflammation within the joint. Prevalence, 45% females. With that said, I look forward to the next time that I sit down on a Tuesday and go through a particular topic about TMD under the title of TMD Demystified. Until next time, I'm Tony Urbanek, and look forward to the next time that we meet.